Good morning, ladies and gentlemen. My name is Dr. Kireki, and I'm a consultant obstetrician and gynecologist, and also the president of the Kenyan Obstetrical and Gynecological Society. Today, I'm going to present to you a topic which is very common, situation which affects very many women, and this is about fibroids. Some of them call them fibroids or fibroids. It is the same. What are fibroids? Fibroids are basically growths of the smooth muscle in the womb of the uterus. What happens is, under the influence of a hormone called estrogen, and estrogen is a hormone which is produced by the ovaries, and this is what makes women to be women, in the sense that is why women have breasts, bigger breasts, they have wider hips, and so on, as opposed to men who generally don't have big breasts, and also their voices are deeper, their muscles are bigger, etc., etc. So these are the differences. Now, estrogen works on the smooth muscle of the womb, and sometimes this leads to fibroids or fibroids, as some people call them. Now, when you look at what we call epidemiology, that is the extent of fibroids in the general population in the world, you find that women of African origin, it doesn't matter whether they're in Kenya, whether they're in the USA, if a woman has African origin, they tend to have more fibroids than other women of other races. We exactly don't know the reason why, but what we do know is that during the reproductive period, that is from around 18, even though women or girls can get pregnant even a lot earlier, from around 18 up to around 40, 45, women of African origin will tend to have fibroids. And this affects about anywhere between 30, even up to 60% of women of African origin. It has also been found that women of African origin will have more fibroids in terms of numbers, and also the sizes of these fibroids are going to be a lot more than women of other races. A colleague of mine wrote a paper, it was a case report, and this was some time ago, where he said, mine are 140, what about yours? Basically what he was saying is that he had taken a lady to surgery, and he had removed 140 fibroids. Can you imagine that? 140 fibroids, and he managed to not to remove the womb. The most I have removed are 80, so I'm quite far from the record which my colleague has. Now, depending on where the fibroids are located, we give them a name. For example, if a fibroid is hanging on the uterus, on the uterus or the womb, we call it pedunculated, meaning it has a stalk and it is hanging. It can hang from the outside. It can also hang from the inside, what we call the cavity, and that is where a baby normally grows. So we call this a pedunculated fibroid. A fibroid can be in the cervix, and the cervix is the entrance of to the womb, as it were, and we call this a cervical fibroid. A fibroid can be in the muscle of the womb, where we call it an intramural, in the muscle of the womb, an intramural fibroid. But sometimes the fibroid can also be just beneath the lining of the womb, and the lining is called the endometrium. So if there's a fibroid which is growing just below the lining, we call it a submucosal fibroid. Now, do all women who have fibroids, will they have symptoms? Actually, about 30% or so of the women who have fibroids will be completely asymptomatic, meaning they don't have any symptoms at all, and the fibroids are basically an incidental finding, meaning the lady came to a doctor, and she came for something different, and during the examination, during doing other extra tests, it was discovered that she has fibroids. For those ones who have fibroids, what are some of the symptoms? I think the most important thing is to listen to the patient. When the patient comes, we ask them questions. For example, when was your first period? Are your periods regular? And how are your periods? One of the things that is very, very critical is to ask whether the periods are normal, whether they are heavy, whether they are painful, and if there are any clots which accompany the periods. And when we ask about the periods, we normally ask how many pads does a patient use. Sometimes patients use pads, and they also use tampons as well, and others use both of them, a tampon and a pad, and sometimes they have to use a towel. And still, these patients have what we call a leakage of the menstrual flow, as it were. So when a patient says that her periods are heavy, we want to know how many days these periods take. For example, if she says they take anywhere between 7 and 10 days, that is already a red flag. And then we ask how many pads she uses in a day. And some of them say, well, I use about 5 pads a day, and all of them are fully soaked. That is also a red flag. And others may say that I use a tampon and I use a pad, and they're still soaked. And sometimes I need to get something extra. That is also a very big red flag. Now, the other red flag are the cramps, because some patients say that I have very serious cramps, and these cramps start on the day of the periods and they continue until the day the periods come to an end. That is also a red flag. And also, when they are clots, or if they are clots, then that together with the other symptoms of the heavy bleeding and so on, and the presence of clots, that is also a very big red flag. Then we can also ask about other attending symptoms. For example, does the patient feel weak? Does she feel lethargic? Does she feel like sleeping? And so on. Because if she has very heavy periods and she has these other symptoms, it means that every time she has her periods, the blood level, what we call hemoglobin level, actually falls. And that is why there is less oxygen being supplied through the body, and especially to the brain. That is why a patient feels weak, she feels lethargic, she can't think clearly, and she wants to sleep most of the time. And then the next step we want to examine this patient after taking the history, and she has told us about her cycles and how they are. We want to do an examination, what we call an abdominal examination. So we ask the patient to lie on a couch, and we expose the abdomen, and then with hands which are warm, we gently palpate the abdomen. We push the abdomen a little bit, starting from the lower side. And the first thing that we have to ask is whether she has any pain, because we want to avoid the place where there is pain for the last. Because if we start by examining that area which is painful, the patient may actually sort of defend herself, and her muscles may be rigid, and we may not be able to feel anything. So we start by pushing gently, what we call palpation, pushing gently the abdomen. And most of the time, if the fibroids are big, we can actually feel them. And we normally equate the size of the uterus with the size of a uterus which has a pregnancy. What do I mean by that? For example, once I have finished examining the patient, and then I can feel that the size of the uterus comes up to the umbilicus. I would say the fundal height of the uterus is equivalent to 20 weeks, because normally if a woman is expectant, when she gets to 20 weeks, that is where the fundus of the uterus would be. And then apart from that, I would also make a notation about whether the surface is regular, whether it is irregular. By irregular, it would mean there are fibroids on the surface, which make the surface of the uterus irregular. Then I would also try and find out whether that uterus is mobile, whether I can push it from one side to another. Sometimes it's difficult to do that, especially if a patient has had some surgery, abdominal surgery in the past. Once I have finished this, so these are two elements. I've taken the history, I have done the examination, abdominal examination. Now I need an extra test or tests to actually confirm that there are fibroids. So we send these patients for an ultrasound scan. And this ultrasound scan can be done in two ways. It can be done through what we call transabdominal, where the patient is requested to drink some amount of water. And the moment she feels like she can't hold the urine any longer, that is when we do the ultrasound scan by using what we call a transducer, which we place on the abdomen. And then this will send waves into the womb, into the abdomen. And these waves will be received back by the same transducer. And they will change those waves into an image. And now we will be able to see that image on a screen. Normally, the transabdominal scan, we do it when the fibroids are quite big and are not easily accessible by what we call a transvaginal scan. A transvaginal scan, sometimes we do both. The transvaginal scan goes through the vagina. We use, again, a transducer, which will send ultrasound waves to the uterus and the surrounding organs. And those waves are collected back by the transducer and they're changed into an image, which we'll be able to see on a screen. So on the ultrasound scan will be able to tell us, number one, where the fibroids are. Number two, we can be able to measure the sizes of those fibroids. Number three, we can be able to count how many of them are there. Sometimes there are 10, sometimes there are fewer, sometimes there are as many as 100 and 100 plus. On the scan, we may not be able to actually count all 100 and something fibroids, but we can see that there is a large number of these fibroids available. So once we have done this and we have mapped, that is, we know where these fibroids are and what the sizes are. So we have all these three elements which now complete our diagnosis. Remember, we did our history, we took our history, we done the abdominal examination. Now we have the ultrasound scan report. Sometimes we send these patients for what we call an MRI, that is magnetic resonance imaging. And this is a much clearer, because it gives a much clearer number of these fibroids and their sizes and where exactly they are located, what we call demarcation. Then we can also do a blood test, because remember, some of these patients come with other symptoms. They feel weak, they feel lethargic, and sometimes they may lose consciousness and so on. So we want to do a blood test. And the blood test will be looking at several things. We'll be looking at their hemoglobin level, that is the level, the amount of blood in the blood, let me put it that way. And then we'll also be looking at their white blood cells, which are very important because these are responsible for infection. We will be looking at their platelets. This is the component of the blood which is responsible for clotting. Say, for example, someone has hurt himself or herself. After a few minutes, there is a clot forms and the healing process starts. If these symptoms have been going on for long, we may also want to look at what we call urea and electrolytes. meaning we are checking to see whether the kidneys are functioning well, because if there is not enough blood passing, circulating into the system, some of the wastes can build up and they can affect the kidneys. So once we have all this together, now we can sit down with the patient and say, look, this is what we are thinking. Yes, you have fibroids, and these are the sizes of the fibroids, and approximately these are the numbers of those fibroids. Remember, we also asked whether there are other symptoms, and which are these other symptoms. For example, whether she has any pressure symptoms. For example, she wants to go for a short call, and when she gets to the toilet, the amount of urine that comes out is a lot less as compared to the pressure she was feeling. Or once she has finished doing a short call, she goes out, and then after a few minutes, she feels that she needs to come back to finish the short call again. And sometimes there can also be when she goes for a long call, she may also feel the same pressure symptoms, meaning once she has finished her long call, she still feels that she needs to go back again, but whatever comes out is a lot less than what she was feeling. So we put all this information together, and then we already have made a diagnosis, and then now it's a question of how do we help this patient? What type of surgery or what type of management would be optimum and best for her? The type of management will depend on several things. Number one, if there are symptoms, in this case, yes, the patient has symptoms. Number two, does she want to have children or not? Has she finished having children? So if she wants to have children, then the type of surgery will be completely different. If she has finished having children, then the type of surgery which we can consider is completely different. And the different types of management. It can be what we call conservative management, whereby, for example, the patient is not ready to go to theater because of whatever reason. Then we use medications. We use what we call blood boosters to increase the level of blood in circulation. We can also use medications which reduce the amount of bleeding that this patient has. We can also use contraceptive pills, combined oral contraceptive pills. They also, to a certain extent, reduce or even sometimes stop completely the cycles. And if they stop the cycles, obviously this patient will feel better. Sometimes we may use a coil which is embedded in a hormone. This also does reduce, sometimes, depending on the location of the fibroids, it does reduce the amount of blood loss and also the extent, the period of time when this lady has her periods. So if she wants to have surgery, or if we think that surgery is the best method, then we sit down with her and explain the methods of surgery. And there are several of them. There is what we call laparotomy, where we take this patient to theater and cut the abdomen. Sometimes we do what is called a bikini cut, or we do a straight, what we call straight abdominal incision, depending on the sizes of the fibroids. We can also do what is called minimal invasive surgery. What does that mean? It means that we make 3 or 4 small 1 centimeter, half a centimeter incisions or cuts on the abdomen. We insert a camera into the abdomen, and then we pump the abdomen with carbon dioxide, and this expands the abdomen, and then we go in with other instruments, and then we are able to operate while watching this operation, what we are doing, on a screen. And it's called minimal invasive surgery because of the small 2, 3, 4 maybe incisions that we make, and we use instruments. And once we have finished the surgery, we just close those tiny incisions, and everything is fine. Sometimes, after a period of time, you find that even those where we made those tiny incisions, actually they disappear and they are not noticeable. Then there is another type of surgery we call uterine artery embolization. And we do this in conjunction with other specialists, where through one of the vessels, we go in through the groin and go and block the blood supply to the uterus by blocking the main suppliers of blood to the uterus, what is called the uterine arteries. What happens is when there is a blockage like that, it means there is no blood supply, and then those fibroids which are being supplied, they start slowly decreasing in size because they can't grow, because there is no blood and there's no oxygen and so on. Now, can all patients have these operations? No. Some patients can qualify for laparoscopic surgery. Others can qualify for a uterine artery embolization. Some patients will qualify for what is called hysteroscopic myomectomy, meaning we do the surgery through the vagina, through what we call the cervix, which is the neck of the womb. We go in with a tiny camera and an instrument, and then we are able to actually remove the fibroid which is in the uterus. So there is no cut on the abdomen. It is basically everything is done through the vagina. What are the conditions which must be fulfilled before we take these patients to theater? Number one, of course, the patient has to agree that she wants to go to theater. So we must have a consent. And the consent comes after explaining to the patient what the problem is and what we would like to do and what will be the outcome, what we call the pros and cons. The pros, obviously, we remove the fibroids. What are the cons? The cons can be quite a number. Sometimes we can injure other organs in the abdomen. For example, we can injure the bladder. We can injure the intestines as well. There can be a lot of bleeding. And actually, this is one of those things which you have to be very careful about when we're thinking about surgery, whether it is open surgery or whether it is minimal invasive surgery. So we must make sure that the level of blood in circulation is okay, first of all. And then we also must make sure that we have extra blood waiting when we go for theater. And then the other thing, apart from that, of course, the patient has to be generally of good health, meaning that her blood pressure should be okay, her sugars must be controlled, and also her kidneys must be functioning well, and so on. Because remember, when we take her to theater, we must give her what is called anesthesia, because this is not surgery which, or any other surgery for that matter, should not or cannot be done while the patient is awake, because it's very painful, and this will lead to the patient not agreeing to go to theater for this surgery. Now, once we open the abdomen, or once we go in with the camera, we will be able to see and discern how many of these fibroids are there, where are they located, what are their sizes, and so on, and then make a plan how we are going to approach them in order for us to be able to remove all of them. What are some of the fears that we have when we go or when we take a patient to theater? Number one, if the patient has an allergy, and if, unfortunately, that allergy manifests or shows itself during the surgery or just before surgery, there can be an interaction of medications for anesthesia. That can be a challenge. And then the other surgical challenges, which I have explained, the loss of blood, infection, and so on. Sometimes when we're doing the surgery, we may have to make a decision about removing the womb, even if the patient may not have given us that consent. And why do we do this? We do this because during the removal of fibroids, if we do find that in the process of removing the fibroids, the patient starts bleeding and bleeding excessively, and we may not be able to stop this bleeding, then we have to make a decision intraoperatively, meaning during the surgery, to remove the womb. That is why it is very, very important to explain to the patient before she goes for surgery that there is such a possibility. It may not be a very high chance, but there is still this such possibility that we may have to remove the womb. And especially if this patient has not had children or has not finished having the number of children that she desires. And then we have another method, which is non-invasive. And this is called HIFU, HIFU, high intensity frequency ultrasound. It uses the same ultrasound waves. Remember, I mentioned about an ultrasound scan. So it uses the same waves. The only difference is that in this case, these ultrasound waves converge, just like if you are using a magnifying glass and you put it under the sun, the magnifying glass converges those waves, light waves, and to one point, and by converging them to one point, it creates heat. And hence, that is why we can actually use a magnifying glass to light a fire, for example. So it's the same principle that is used in HIFU, where the ultrasound waves converge and they create energy, they create heat. So we use that heat to actually what you call ablate or burn the fibroids. And this is a method of treatment. It is a non-invasive method. What does that mean? It means that we will not cut anywhere. The patient does not need blood. The patient does not need a theater. What the patient basically needs is an ultrasound scan and an MRI. Because the MRI will show us exactly where these fibroids are. That is number one. The sizes of these fibroids, number two, and whether there are any other organs which could be on the way, because remember, we are going to use energy in order to treat these fibroids. Once we have made sure that there are no organs near the fibroids which can be affected by this heat path, then we map these fibroids on a screen, and then we make a plan on how we are going to approach the treatment of these fibroids by using that energy. It is a new technology in Kenya. And by the way, we have, I think, only about 6 such machines in the whole of Africa. 6. We have 1 in Cairo. We have 2 in Nigeria, 1 in Lagos, 1 in Abuja. We have 1 in Nairobi, 1 in Tanzania, and then 1 in Johannesburg. You'll agree with me that this is a very, very small number. And again, because the technology is new, we need to enlighten people about its availability and what the advantages are. What are the advantages of having HIFU treatment so long as the patient qualifies? Number one, it is a day procedure. Patient is treated and she goes home. There is no recuperation period, for example, compared to open surgery, where the patient has to stay in bed for 3-4 days, and then she goes home and she has, to slowly start recovering from the surgery. Number 3, we don't need blood. Blood is very difficult to come by, so we don't need it and for HIFU treatment. Number 4, the patient doesn't get anesthesia. She is not put to sleep, as compared to when we are doing open surgery or when we are doing laparoscopic surgery. Does the patient need medications, pain medications after HIFU treatment? Yes, she may need some analgesia, some painkillers. And the painkillers usually are very simple. Can be a paracetamol, which basically most people use from time to time, or it can also be ibuprofen, for example, which again is very common, and we use it almost on a daily basis for some people. Does she need to stay in hospital? No. Usually after the procedure, which will take anywhere between 1 and 3 hours, she is monitored after the procedure, whether there's any pain, whether there's anything that is not okay, and after that she's discharged. In case something happens, in case the patient, for example, starts having pain and so on, she is free to call the clinic and she will be advised on what to do next. So in summary, what am I saying? We are saying that, number 1, fibroids or fibroids is a very common problem. especially among women of African origin. Number two, women of African origin have more fibroids in terms of numbers and also in terms of size. Number three, some women may not have any symptoms, but they have fibroids, and sometimes these fibroids are an incident of finding. Number four, there are various methods of treatment. Some of them are conservative, where we use medications, and they can be surgery, where there are different types of surgery, open or minimal invasive surgery, or uterine artery embolization, and lastly, a non-invasive method, which is called Hifu, high intensity frequency ultrasound. And lastly, is Hifu safe? Yes, it is very safe. At the moment, I know that this center has done about 40 cases, and they have all been successful, not even one complication. Is Hifu readily available in Africa? Not very readily available, but we have started the process of making this method available to our Kenyan women and also others from the surrounding neighboring countries. So I want to thank you very much for listening to me, and we want to welcome you. If you have any questions, we are more than happy to answer them, and also tell a friend to tell a friend about this new method of treatment of fibroids, which is readily available in Nairobi. Thank you very much. And you can call the office number, and the office number is 0778 930 100. I'll repeat, the office number is 0778 930 100. Thank you.